Okay, great. So, oops. Hello, my name is Gwen Driscoll. I am the Director of Communications here at the UCLA Center for Health Policy Research. It's my pleasure to welcome you once again to our 2016 Health Policy Seminar Series. Before I begin introducing today's speaker, I just want to make a brief announcement about next month's seminar. Please save the date of Thursday, March 10th for a seminar related to a study to be released on the same date on the prevalence of pre-diabetes in California. Nearly 10% of the adult population in California have diabetes, but how many more have the conditions that presage the onset of diabetes? And how can the path towards diabetes be reversed? Center researcher and chronic disease expert Dr. Susan Babby will discuss the results and the policy implications for both the state's health and budget. And it should be very interesting, so please join us. As for today's seminar, we will be recording it, as always, and it will be placed on our website at the address you see at the top of this slide. If you would like copies of today's presentation slides emailed to you, please send me an email at gdriscoll@ucla.edu. Please also note we will have a brief question and answer period at the end of today's seminar that I will moderate. And if you are interested in our upcoming seminars, events, and presentations, data and research, which is all free, please subscribe to our very popular e-newsletter once a month, Health Policy News, and that is the address at the bottom of this slide. Okay. I am now very happy to introduce today's presenter, Dr. Stephen Wallace. Steve is, of course, the Associate Director of the UCLA Center for Health Policy Research. He is also a Chair of the Department of Community Health Sciences and a Professor at the UCLA Fielding School of Public Health. He is also the Director of the Coordinating Center for the NIH-NIA Resource Centers on Minority Aging Research, which is a national initiative. Steve is a leading national scholar on aging, especially in communities of color. He has published research on access to long-term care by diverse elderly groups, disparities in the consequences of health policy changes on racial and ethnic minority elderly, as well as on the politics of aging. He is also, in his spare time, an expert on immigrant health and health policy for immigrants. Since 2007, Steve has led efforts to expand our understanding of poverty in California for our vulnerable senior citizens through the Elder Index, which is a cutting-edge poverty measure that takes into account the real cost of living in all 58 California counties. The center has published several years of data on the Elder Index. It's all on our website. I do recommend you check it out. It's very comprehensive. And in this seminar, and in conjunction with a fact sheet released today, which is also on our website, main page, Steve will discuss how living above or below the Elder Index has direct impacts on health and access to health care. He will also talk about the inadequacy of current poverty measures like the federal poverty level, and how the Elder Index can help policymakers and others understand the gap between so-called official poverty and the poverty that hundreds of thousands of Californians unofficially struggle with every day. Please welcome Dr. Stephen Wallace.
Thank you, Gwen. Okay. So we queue up here. Oops. We're on about slide 23 there. Don't look, don't look. There we go. Okay, well, thank you and welcome everybody. I'm glad to have you both online and in person. And I want to wish you a happy Leap Day. So this is an extra day this year that we all get. So we can spend some time thinking about the Elder Index. So should I advance it or should you? Okay. So I want to start with acknowledgements. The funder for the Elder Index, a lot of its development and for the data I'm going to present today has mostly been supported by the California Wellness Foundation. And before the Wellness Foundation started funding us, we had a whole variety of funders. So I want to call out Wellness Foundation because they've been our major source of support. We've had a lot of partners in our work over the last almost 10 years, the most important one being the Insight Center for Community Economic Development in Oakland. They're the ones who brought us into this work. They invited us to partner with them in doing the technical and research aspects around the Elder Index, and have been key in making it policy relevant and making it work on the ground. They've also been working with Wider Opportunities for Women in Washington, D.C., and the Gerontology Center at UMass Boston. And then finally, over the last 10 years, there's been a number of researchers, most recently and importantly, Imelda Padilla-Frausto, who's here. Luis Sosa has been helping us recently as well, and a number of others. So I want to thank everybody. As with all successful work, it's the part of a team, not just a person. Okay, so today I'm going to do, as Gwen said, talk about the federal poverty line, how we got to where we are, why it's not adequate, who the people are that aren't being looked at by the federal poverty line, or the hidden poor as we've been calling them, and then how this affects their health status. So apologies to people who've heard this before. For those of you who haven't, I think it's important to understand how we got into the mess we're in. During the Great Depression in the 1930s, poverty was a major problem in the United States, but there was no way to measure poverty. So in Franklin Delano Roosevelt's second inaugural, the most accurate way he had of describing the economic status of millions of Americans who were suffering without jobs in that era was to say, I see 1/3 of a nation ill-housed, ill-clad, and ill-nourished. And in the 1930s, that was the technology of the time. There was poverty was an impressionistic concept. While there were lots of people out of work, homeless, living on the streets, there was no clear measure of who was poor. So go forward to another inaugural, another president, the 1964 State of the Union address by President Johnson. Once again, looking at the numbers of people who were poor, and he declared a war on poverty. In his State of the Union address, he said, "This administration today, here and now, declares unconditional war on poverty in America. Our aim is not only to relieve the symptoms of poverty, but to cure it, and above all, to prevent it." But at that point, there was still like during the Depression, there was no metric. How do you know if you've cured and prevented poverty if you don't know how much there is? So they had to come up with methodology, and they used the data that were available at the time. They wanted some standard to assess their progress, and it had to give you a number that was large enough so that you could actually reduce poverty, but not so high as to make the country look poor. So there were a lot of contending metrics at the time, and in 1965, what they chose is the metric that we still use today. The Federal Poverty Guideline was based on a 1955 survey, so it's almost 10 years out of date even then, that found that 1/3 of family expenses were spent on food. So they had that. They didn't have a whole lot of other data that we have today. One thing they did have was an annual survey by the Department of Agriculture of how much food cost. And so there were 4 different menus that the U.S. Department of Agriculture put together for dealing with how much you needed to spend on food. And they looked at multiplying those numbers by 3, if 1/3 of your income was spent on food, to come up with the poverty line. And as they looked at what the total amounts were at different food levels, they ended up with the very bottom emergency food plan as the food level that they multiplied. The emergency food plan was designed for sort of a post-Katrina circumstance where you needed to eat on a very small amount of money for a very small amount of time, but that was the one that they did. So emergency food plan times 3 is the poverty line. That was established in 1965. They've updated it for the Consumer Price Index, but it's still based on that today. So anybody here know what that car is in the picture? It's an Edsel. So what's famous about the Edsel? It was a failure. So I put that up on the screen advisedly. This was the era that the federal poverty line was used. The metrics came up for the federal poverty line, and I would say it's about as successful as the Edsel. Oops. So I just pushed something. Rick? What did I just do?
I think we stopped sharing.
I pushed it, and I don't know what I did. Yeah, thank you. Okay. So there's at least 3 major problems with the federal poverty line as it was designed. The first was in 1965, the only data that they had were national level data, so they weren't able to include any regional variation. By 2016, adjusting the 1965 amount for inflation comes up for a single person to $11,880. So that means anybody in the country is expected by the federal government to be able to survive on something close to $12,000 per year. Whether you're in LA or San Francisco or somewhere in the rural Midwest. So obviously the lack of any geographic variation is a problem, and I'll show you some more data on that shortly. So I'm pressing the space bar and it's knocking me out. I was pressing the space bar before and it was okay. Sorry for the technical difficulties here. Okay, so I'll click this instead. Okay, so the first problem is there's no geographic variation. The second problem is, if you remember, the federal poverty line was based on a family income, and that was basically 2 adults and a child. But the distribution of household expenditures for older adults varies dramatically from that of younger adults. So as you can see in this chart from 2014, pretty much across ages, the proportion of income that is spent on food is much lower than 1955. It's about 11%, not a third. But if you look at, let's see if I can do this without messing it up, the proportion spent on health care for older adults, the older you get, the more of your income goes for health care. So health care in 1955 was an insignificant portion of the market basket for persons, and today is a significant amount for seniors. I'll show you some data on that soon too. The third failure of the federal poverty line is that it doesn't account for different housing types. What this shows you is nationally the proportion of older adults who rent their homes, own their homes while still paying a mortgage, or own their homes and don't pay a mortgage anymore. So the average view of older adults is they live in their homes and they're paid off. But when you get down to lower income, so this is under 200% of the federal poverty line, only non-Hispanic whites have a majority that live in their home with no mortgage. Among African Americans and Latinos, the most common housing type is renters, with about 2/5 of each of those groups renting their homes, and only about a third living in their homes with no mortgage. Even 25% of non-Hispanic whites are renters. So the types of housing that older adults live in also has a major effect on their needs for income. So it should be no surprise to you when you're talking about housing, you're talking about costs that diverge wildly. And this is the source of most of the geographic variation in the cost of living in the United States. San Francisco in 2015, the Housing and Urban Development, U.S. Department of Housing and Urban Development, established a fair market rent, which is based on the 40th percentile of apartments for rent in the area. That means fewer than half of the apartments rented for this or less. So their fair market rent was $1,635 for a one-bedroom apartment. And friends that I have in San Francisco laugh when I tell them that. In Los Angeles, it's less, it's $1,100, but once again, if you've been on the market recently looking for a livable one-bedroom apartment, $1,100 is not a lot of money. When you get down to Des Moines, Iowa, the fair market rent is $500. So you can see a factor of 3 between Des Moines, Iowa, and San Francisco with LA in the middle. So there's a huge geographic variation in the cost of housing. And as you remember, the federal poverty line is the same across the entire country. So to address these and other limitations of the federal poverty line, we and the Gerontology Institute at UMass Boston, WOW, and the Institute in Oakland have come up with an alternative, the Elder Economic Security Standard Index, which is a mouthful, so we just call it the Elder Index. It's based on 5 components, which is different than the federal poverty line. It's based on the actual costs that seniors face at the county level, not nationally, at the county level for healthcare, for housing across 3 different types of housing, for food at home, no going out to McDonald's, just eating at home, local transportation, and a small amount for miscellaneous. So when we were developing this in California, I argued that we should include the cost of basic cable service, because for a lot of seniors, that's their only view to the outside world. The consensus was this needed to be a stripped down quantity that really is just a very basic cost of living. So it's basic phone, clothing, and a little bit of home repairs. So this is really, as we look at the numbers, remember this is a very basic standard of living. It's not an extravagant standard of living at all. So when you look at the numbers for 2013, you can compare Los Angeles City with Humboldt County. There's several stories in this. The first is the cost of housing. If you look at owner without a mortgage versus a renter, you can see the huge difference between the cost that somebody who owns their home and has it paid off faces versus those who are renting. But even owners who have their homes paid off do not face zero cost. They're still paying $400 to $500 a month, and that's for taxes, insurance, utilities, right? There's a lot of costs to owning a home above and beyond your mortgage. So thinking that seniors who have paid off houses have free houses is a misnomer to start with. And then when you look at the 40% of African Americans and Latinos, actually in California it's closer to 50 to 60%, who rent, you can see that their costs are twice as much as those who own their homes. So housing becomes a huge cost and varies between the city of LA and Humboldt, both in the owner costs as well as the renter costs. Food is relatively constant across the state. Transportation, we don't have good intra-state data, so that's the same across regions. Healthcare varies quite dramatically. So the cost of healthcare, this is for a Medicare Advantage plan if they're in a county that has a Medicare Advantage plan, or it's a Medicare supplemental policy, both for the medical care costs as well as for prescription drugs, plus out-of-pocket costs. So, why would LA County be cheaper than Humboldt? I thought LA was a big city that was more expensive. Anybody know why Los Angeles would be cheaper for healthcare for seniors?
More availability of health plans.
More availability of health plans. How much does a Medicare Advantage plan cost? How much extra does it cost in Los Angeles County? Come on, I know there's a lot of healthcare people in here. It costs nothing extra because of the way that CMS calculates the reimbursement for Medicare Advantage plans in Los Angeles County. You can get a Medicare Advantage plan that covers your prescription medications and provides very low out-of-pocket costs for no extra money. In Humboldt County, there are no Medicare Advantage plans, so you end up paying for, we use an AARP supplemental health care plan plus a Medicare prescription plan plus the other out-of-pocket costs. And so actually the cost of health care in Humboldt County is twice as much. And then your miscellaneous costs. But the bottom line on both of these is that a renter is going to be between $22,000 and $24,000 a year. Anybody remember what the poverty line was? It was a lot less than that. So here's the statewide average is about $23,000 for a renter. The federal poverty line is a little over $11,000 in 2013. And so the federal poverty line is about half of what the average older adult in California needs to make ends meet. Now, if you own your home without a mortgage, it's a little closer, but still more than the federal poverty line. And if you are one of the unfortunate 20-25% who are still paying a mortgage, you're woefully behind. The other interesting piece on this is you can see the costs in Humboldt for housing for an owner with a mortgage is $372 a month. The cost for healthcare is $359 a month. So in some of the rural counties where you don't have Medicare Advantage plans that are available, where you're paying a lot more out of pocket for healthcare costs, the costs of healthcare can be as much or more as the cost of housing. So when you look at couples, the costs of housing are about the same because you need the same quantity of housing for a single or a couple. Right? They share the same amount of space. But you now have two people paying for healthcare costs instead of one. So in 43, most of California's counties, 43 out of our counties, for a couple, the cost of healthcare for those who own their home without a mortgage is more than they're paying for housing. So once again, the cost of healthcare, remember the slide that showed the proportion of older adults' expenses that go for healthcare, can become a major expense for older adults and needs to be accounted for. So, who are these people that are above the federal poverty line, but don't have enough money to make ends meet. The group that falls in this yellow gap here. Last fall, end of the summer, we did a policy brief, which you can find online. Actually, the URL is there, but it's in blue, so you can't see it. But if you look up on the center's webpage, we do have a whole policy brief on the hidden poor. Briefly, the hidden poor are disproportionately elders of color. What you can see here is among Latinos, African Americans, and Asians, almost half of older adults or more have incomes below the elder index. Within each of those groups, the blue bar is those who are the hidden poor. That's the group that isn't identified by the federal poverty index, but don't have enough money to make ends meet. And then the red bar is the official poverty line, which, as I've already shown you, is an inadequate amount. So across every group, including non-Hispanic whites, the number of poor who are the hidden poor in that group between the federal poverty line and the elder index is at least twice as many as below the federal poverty line. So when we look at poverty and say, oh, poverty among the elderly is pretty much taken care of, it may be the poverty is taken care of, or the poverty number in poor is relatively low compared to other groups, but the number above that who don't have enough money to make ends meet is actually several times the number who are poor. Okay. So, if you don't have enough money to make ends meet, that means you don't have enough money to pay an adequate rent, so you may live in substandard housing, or you may not have enough money for food, so you might scrimp, you might go to the local food bank. But what is the impact of not having enough income on your health? And so that's actually the focus of the fact sheet that we released today, looking at the health problems among California's hidden poor. So we all know that poverty is related to poor health, poverty is related to a lack of access for health care. But what about those people who have incomes above the poverty level, but not enough to make ends meet? So I'll start with the basic self-assessed health status, that 12-word question that's on all surveys. Overall, would you say your health is excellent, very good, good, fair, or poor? For older adults, we typically combine fair and poor. This is a measure that may sound a little subjective. It is, but actually is better than physician exam in predicting 5 and 10-year mortality. It's highly associated with chronic conditions, disability, and other areas. So it's a good overall measure of health status. So when you look in California Health Interview Survey for 2013-14, and you look at older adults who are living alone, so singles, or living only with their spouse, so we simplified this for the sake of the analysis, see that almost half say that their health is fair or poor. When you look at that group right above the poverty line but below the elder index, those who we say still can't make ends meet given their income, about a third say their health is fair or poor, and then for those above the elder index, it's 17%. So about twice as many hidden poor say their health is bad as those in a higher income. Now, normally when we do an analysis, where do the hidden poor end up? Which group? If we're just going to dichotomize, what do we always do in our analyses when we're talking about? So the hidden poor end up in that group that says above the elder index. So you end up with those who are below the federal poverty line and those who are above the federal poverty line. So what you end up doing is the hidden poor, and that's why we call them the hidden poor, end up in the much larger above the elder index group. And so the needs of that population basically disappears. What this does is breaks out that group right above the poverty line and shows that their self-assessed health is much worse than that larger group. So if you're going to combine them, you should actually combine them with the poor, not with the above the elder index. So now, health tends to be a life course phenomenon in addition to current circumstances. So how might we explain the fact that there are so many people with poor health among the hidden poor. In part is if you look at the educational profile of the people in poverty, the hidden poor, and those above the elder index, you see that the poor and the hidden poor are much closer in educational attainment than those above the elder index. About a quarter of the poor and about a quarter of those who are the hidden poor have less than a high school education. So that means that they've had lifelong experiences of having limited incomes, likely had occupations that were difficult and taxing, and have likely had a lifelong exposure to inadequate health care. In contrast, for those above the elder index, 2/3 have some college. So what you're seeing here probably in part is a reflection of lifelong experiences of lower income, lower access to health care, difficult occupations, and then present circumstances that are also occasioned by having inadequate income. So higher health needs for overall health, higher health needs for depression. Once again, a similar pattern. In fact, in this case, the proportion of older adults whose income is below the federal poverty level has a similar level of depression as those in the hidden poor group. The 10.2 versus 10.6 is not statistically different, but is different than the 3.4 in that higher age group. So once again, this is related to a whole host of circumstances that the hidden poor find themselves in, including economics is highly associated with depression, health status, social support, and other types of living circumstances. So once again, if we, as we normally do, simply do poor versus non-poor, that hidden poor, which has a much higher need for mental health services, disappears into the above the elder index group, and we ignore their needs and their life circumstances. So higher general health, higher psychological health needs. So you would think that they would be needing to get care. But when we ask them if they have tried to get care in the last year, the majority of all older adults have tried to go to see the doctor. And then we ask them, how often were you able to get an appointment within 2 days? So this looks at difficulty in obtaining timely medical care. So this is the group that said they never or only sometimes were able to get an appointment with the doctor within 2 days, which is the standard, versus usually or always. So we just dichotomized the numbers. So almost a third of those in poverty said they had difficulty getting a timely appointment. About a quarter of the hidden poor said that, and about 1 in 10 above the elder index. So once again, a group that has high needs is also experiencing high levels of difficulty in getting the care that they need. So why might this be? All right, so those of you who are statisticians will understand this. I apologize to the general audience who may be with us. So I did a regression analysis looking at those who said that they had difficulty obtaining timely medical care, and then looked at the odds ratio. This is a measure of the difference between the difficulty for those whose income was above the elder index, that's why it's 1. 1 is the reference group. And then comparing those who are the hidden poor and those who are under the federal poverty line. So the red bar is unadjusted. It's just the red bar is basically the same as this, except in a ratio. So if you had an income above the elder index, you were twice as likely, if you were hidden poor, to say you had difficulty obtaining timely medical care, and 3 times more likely if you were below the federal poverty line. So this is pretty much what I just showed you in the nice, simple, and to understand bars. So then we know these populations differ, so we controlled for age and sex, and the older you are, the more likely you are to have difficulty. No difference by gender, a little more difficulty if you have poor health, a little more difficulty if you're depressed. And so we accounted for those differences between the populations, and you see that the variation from above the elder index went down a little, from 3.3 to 2.9 on the poor, and 0.21 to 1.9 on the hidden poor, but still much higher. So then we added whether or not they had Medi-Cal and usual source of care. Once again, no usual source of care is highest among the poor. About 10% have no usual source of care. About 6% of those who are hidden poor have no usual source of care, and about 1 to 2% above the elder index. So controlled for those sort of access characteristics, and the numbers came a little bit closer, but still different. And then added rural and race ethnicity. Did a urban-rural distinction because the large number of seniors that are the hidden poor are disproportionately in counties that are rural counties. So those are areas where they have high healthcare costs, often renters. But once again, so after you control for all the differences in the composition of these three groups, you still end up with both those under the federal poverty line and the hidden poor about 1.5 times more likely than those with incomes above the elder index to report that they have difficulty obtaining timely medical care. So what's interesting here is you actually tend to equalize the hidden poor and the poor, and they are both continuing to be different from those above the elder index. So we could ask, what is it? What's remaining? What's leading to these higher rates of difficulty in obtaining timely medical care? Could be where they live. Because of their income and education, they're probably more likely to live in medically underserved areas. When you look at some of the contextual variables around, do people trust their neighbors? Are they afraid to go out at night? It's higher among those groups than the wealthier groups. So there is likely to be a whole set of contextual variables that are affecting their ability to get care too. The bottom line being, though, that being hidden poor or poor has an independent effect, net of what we typically look at in health services research, on their ability to get timely medical care. So once again, another rationale for why we should pay attention to the hidden poor. So this was the data without the regression was in the fact sheet. The data on the hidden poor is in the California Health Interview Survey. You can look that up at the Ask CHIS website. It's not loaded yet for 2013-14. It will be soon, but it is up there for 2011-12. So if you have other conditions, other outcomes, other questions that you have, you can look at that on the Ask CHIS website. So there were a couple other conditions that, after we put the fact sheet together, came up. So I thought I would briefly present some data on that, one of which was diabetes. So logically, diabetes is associated with poverty. It's also associated with being the hidden poor. And in fact, the hidden poor is statistically more likely to have diabetes than the poor. And both are more likely to have diabetes than those above the elder index. Since I just ran this in the last day or two, I don't have an easy or facile explanation for this. It is possible that at advanced ages you see the poorest of the populations are dying and no longer in the poor. And so that could be a mortality effect as to why it's a little bit lower. Or there could be other reasons for that. But once again, it's another example of where need is substantially higher among the hidden poor. And so you would hope that if they had high levels of diabetes, they'd have high levels of management. But when you ask people with diabetes if they have a management plan, once again, both the poor and the hidden poor are much less likely than those with higher incomes to say that they have a diabetes management plan. Now, this doesn't mean that the doctor didn't make them one. This just means when you ask them on the telephone, do you have one, they say no. So functionally, whether or not they were given one, if they don't know they have one, they're not going to be following it. So you're likely to have a much higher complication rate, not only because these are individuals who don't have enough money for decent food, who may be in inadequate housing, but also because they are less likely to have the knowledge about ways of managing their diabetes. And then one last preventive service, which is actually from, oops, this is 13-14, sorry, that's 11-12, is whether or not seniors got flu shots. And once again, it's not a surprise given the problems with access to care that older adults under the poverty line and the hidden poor are less likely to have had a flu shot in the last year than those above the poverty line. So we've seen that older adults who are the hidden poor have higher healthcare needs. They suffer from more barriers in access to care, and we could predict over the long term that they would have worse outcomes as a result of that. So since we're a health policy center, what can we do about that? So we've identified a problem. Where do we go? Well, to the extent that the problem is current levels of poverty, improving incomes of low-income older adults is a logical solution to dealing with the problem of the hidden poor. California, during the Great Recession, reduced its contribution to supplemental security income, which is income for low-income seniors, and is just now starting to backfill some of the cuts that it made. But the maximum SSI and SSP grant continues to be woefully inadequate compared to poverty, let alone the elder index. And so improving SSI grants would be a step in the right direction. As you saw, one of the largest costs for many seniors is housing, especially those in rentals. And as you all know, we're facing a crisis in affordable housing in California, especially in urban areas. And there's a number of attempts to establish housing trusts, create new low-income or market rate housing for persons with low income. And we need to go back to the era where the federal government made substantial investments in affordable housing. So by improving the housing stock, we could improve the incomes of older adults, which would make a major improvement in their health status. Then there's access to food, healthcare, and transportation. Some of this is related to the economic aspects in terms of improving the resources they have, such as if we improve the cash value of food stamps and SSI or increase the number of seniors who have food stamps, that improves both their nutrition, which would improve their health status, as well as improve their economic situation. We can improve access to Medi-Cal without a share of cost or public transportation, all of which would improve the economics. But when looking at the access to care issues, it looks like there's also some system issues that we need to attend to in terms of making access to health care accessible and available to older adults regardless of their incomes. So the Elder Index, which looks at the actual costs faced by seniors at the county level across 3 different types of housing, and which is updated regularly, is a measure for the 21st century, just like our little car on the left-hand side here. This is not, actually we should go to some of the auto manufacturers for some underwriting. But so we've moved into the 21st century in trying to identify the needs for older adults, but we're still stuck with our old Ford Edsel clunking along, informing health policy and informing decisions around access to care. So in sum, we cannot ignore economic security among older adults. Their economic security is common among older adults. It's actually several times higher than the proportion that are in poverty. It varies by county, it varies by region of the country. And to adequately and accurately identify those who are economically insecure, those who are the most likely to have problems with health, with access to care, we need to use an accurate tool, and I suggest that tool is the Elder Index. When you use that tool, we see that healthcare needs of the hidden poor are high. They're much more similar to those of people living in poverty than people with higher incomes. And when you look at their access to care, the services that they receive, they once again are more like those who are living in poverty than those who have higher incomes. So to be accurate in healthcare planning, in identifying services and identifying those in need, it's important that we use a measure like the Elder Index to assess the needs of the population. And in fact, several years ago, the California legislature passed AB 6380, passed a bill that required the area agencies on aging to use the Elder Index as part of their planning so that counties around the state, including high-cost counties like San Francisco, as well as lower-cost counties like in the Central Valley, which still have cost of living above the federal poverty line, would be able to get an accurate measure of the need of the seniors in their areas. So at the bottom line, by ignoring those whose incomes are above the federal poverty line but inadequate to make ends meet is not only wrong, it's an ethically wrong thing to do, but it's also harmful to their health and prevents us from prioritizing them to receive appropriate levels of care for their health. And it's the minimum we should do for seniors who have spent their entire lives helping build California, contributing to our country, that we let them suffer in silence. And so the call is to take the hidden elderly and not hide them anymore. And I think with that, I want to thank you. So we have time for questions and answers.
We do. So I'm going to take one from the room, one from online, and so on and so forth. And I already have one from online, so I'm going to, since they jumped the gun, I'm going to go with that. So there's a question on, is there a question on CHIS regarding isolation? Was this measured by over 65 by income? Could it be? Because this implies another possible intervention, especially if it's prevalent in rural areas. And if you could repeat the question. Do you want me to repeat it for you?
If you can scroll, I can reread it. So the question was about whether CHIS has a question on isolation and whether it varies by income and rurality. I think that was the sum. So in the California Health Interview Survey, they do ask about household size. So you could assume that a person in a household of one is living alone. What you don't know is, are they living in the same building if they're in an apartment as a family member, or are they living nearby? There, in 2003, were a series of social support questions that asked if you had somebody who could help you out when you were sick, who you could go spend time with. There were 4 different social network questions. Those have not been reused since 2003, and the Elder Index is not available except in the last 2 cycles of CHIS. So we wouldn't be able to look at that. So I guess the short answer is I don't, unless there's somebody here from CHIS who knows otherwise, I don't think there's really any socialization question currently being asked in CHIS. So the best you could do would be looking at living alone.
Question from the room?
Under the ACA, the Medicaid coverage expanded to high, a bit above the poverty level. So how that interpret to the elderly, apply to the elderly?
So Medicaid for older adults is complicated because if you have high medical, the question was how the ACA and the increasing eligibility levels for Medicaid might affect the elderly. So there was already a spend down possible, so a lot of seniors were able to spend down. The total cutoff didn't rise that much for seniors, so the Medicaid impact on seniors was relatively minor from the ACA. What's been a bigger impact has been the move, or the attempted move in a number of counties to move them into mandatory managed care for Medicaid and for Medicare. And that's another seminar. So it's complicated. Actually, it's not really reflected in this data yet. The numbers are still relatively small. So I did look at whether managed care, being in a managed care plan, affected access to care, and that was not a significant variable. But there is an attempt to try to better coordinate the Medicaid and Medicare among seniors. That's part of that.
Do you see the Elder Index being accepted nationwide as a replacement for the federal poverty level? It's a question from online.
Okay, so the question about whether or not the Elder Index is going to be accepted nationwide as a replacement for the FPL. This gives me an excuse to talk about a survey we did of California legislators. that Imelda was responsible for about 2-3 years ago. So we asked legislative staff in California, and we had a really good response rate, what characteristics of a measure of economic need they would like to use. And then we asked them which measures they actually used. So it's no surprise the most common measure they used for economic need when doing program planning and evaluation and all that stuff was the federal poverty level. We gave them, without telling them what it was, the descriptions of 4 different types of poverty measures. The Elder Index, which is a measure of the actual costs of living. The Supplemental Poverty Measure, which is a census measure that's been developed over the last several years that looks at not the cost of living, but what people spend. But it is regionally adjusted, so it does vary by region. The European approach to poverty, which is a proportion of the median income, so it rises as the standard of living rises. And then a measure based on a 1950s standard of living that's been adjusted for inflation, which is the federal poverty line. And as no surprise, what ranked the bottom, nobody wanted, was a single national figure based on a 1955 standard of living, but that's what they all use, right? So that, I hate to say it's a little bit of a trick, but they said this is the least useful to us. Something like the Elder Index was the most useful, the Supplemental Poverty Measure was the second most useful, and so we had this quantitative data, and we actually went and talked to some legislative staff and said, so how would you explain this disconnect? And the disconnect was explained because, well, we've got 50 years of data on the federal poverty line, and the federal government requires us to report it, and we can compare it between states. And then we had a couple legislative staff that said less kind things about laziness and lack of imagination and so forth. But the bottom line is the problem with the federal poverty line is it's institutionalized. There's a concern that changing to something like the Elder Index would cost a lot of money, and you don't have to adjust, so you can still use 133% of FPL as your eligibility level for Medicaid, but instead of saying 133% of poverty, which sounds very generous, right? It's above poverty, you say, well, it's about half the Elder Index. Doesn't quite sound so generous. So actually the first time the Elder Index bill passed in the legislature to require AAAs to use it, it was vetoed by Governor Schwarzenegger. And I learned a new term in the veto message, cost pressure. So it wasn't going to cost the state a penny. It was going to be calculated by the Center for Health Policy Research. It's going to be funded by foundations and other sources. There was no out-of-pocket cost to the state government for using the Elder Index, but what the veto message said is it will cause cost pressure, meaning if you realize that there's 3 times as many people in need as we say now, that will inevitably cause pressure to increase eligibility levels for food stamps and for Medicaid and for housing subsidies. So it's a very long answer to the question of will this be adopted nationally? Not easily, because legislators worry not. You could make it cost neutral, switch over to the Elder Index or the Supplemental Poverty Measure, but then you would know that you're not reaching anywhere near the population that's in need, and that would inevitably create pressures to improve and expand public programs. So the first public critique of the federal poverty line was made in 1995 by National Academy of Sciences, and they published a report which I have a slide in another presentation with a long quote from, but they basically said it was outdated in 1995. So that was 20 years ago it was outdated. And that was sort of a top-down approach. That was experts looking at it and saying, this doesn't measure what it's supposed to measure. 65, it was the best they could do, but we can do a lot better now. And that was 20 years ago. And nothing really has changed. So the Elder Index, and there's a family standard, which is for below 65, which is a similar metric, is being used on a state-by-state level. So instead of a top-down approach, it's more the tobacco control, bottom-up approach, and getting local organizations, AAAs, local agencies to say, gee, this is really a much better use of data for our planning purposes, for identifying need, trying to get it adopted more and more at state levels, and then eventually put pressure on the federal government. So In the next Congress or two, I would say no. If states around the country, and this is part of a national effort, we're the California hub, but there are hubs in Massachusetts and Michigan and Florida and Texas. So if all of them continue to get the Elder Index and its partner metrics adopted at the state level, then there could eventually be enough pressure at the national level.
So, like you're saying, the federal poverty line has a long history of critique, and this, like you said, again, supplemental
Poverty measure
is vastly preferred, and it's been sitting around because it has this history and there's value to continuity. So I'm wondering two things. One, how different is, or have you looked at how different EDI is from the supplemental poverty measure? And could you reiterate what's special about the elderly population more broadly that would require a unique measure that we can kind of maybe bring to other populations when we think about the hidden poor among single mothers, or
Sure.
about that?
So the supplemental poverty measure was developed by the Census Bureau in response to congressional concern about the inadequacies of the federal poverty line. It looks at actual spending versus needs. So it says how much do people spend on housing, which if you're low income, you may not spend a lot of money on housing because you don't have it. So you may double up, triple up, be in substandard housing, and it measures your actual expenditures. What the Elder Index does is look at need, which says to be able to get into a decent apartment, what is it going to cost you? So there's a gap there. It may sound like a fine distinction, but it's the need versus actual expenditures. So that's one difference. The other difference is, so supplemental poverty measure looks at MSA level. It's a little larger level for housing versus county level. It does include a little better detail. So instead of, we look at need for health care, they look at actual spending on health care. So if you have a catastrophic illness, you will be in poverty according to the supplemental poverty measure, where you might not be with the Elder Index, because ours takes like a uniform. In LA County, this is the average need, versus supplemental poverty index is person by person. But then you still have to come back, say if you're doing program eligibility, to some number, some cut point. So it's the total number of people who fall below the supplemental poverty index for elders. So if you go poverty line, it's low. It's like 8 or 9% poor. If you go supplemental poverty line, it's about 15 or 16%. And if you go elder index, it's about 25 or 30% nationally. So it's moving in the right direction, but it's still quite a ways off from that minimum standard of living.
So we're at an end, but I did want to get one more question to your question.
Other than on an aggregate basis, were you able to draw any correlates between no regular source of care and the lack of the treatment plan for diabetes?
So people without for the diabetes, no, I didn't do any further analysis on that. I was just looking at the difficulty in getting an appointment. It's a logical assumption. If you had no usual source of care, you'd be much more less likely to have a treatment plan. So, could do the same analysis around the treatment plan for diabetes as I did around the difficulty getting a timely appointment.
And I guess I'm asking for both sides of that coin. No regular source and regular source. How does that correlate to treatment plan?
Logically, you would say no usual source of care would be much less likely to have a treatment plan than a usual source of care. The question then is, how much of that is explains some of the differences between the poor and the hidden poor versus others. So the numbers without a usual source of care among older adults is relatively small. So the fact that 10% of older adults in poverty have no usual source of care is a little shocking, because most seniors are pretty regular users of medical care. The numbers who are above the elder index with no usual source of care, like I say, is like 2 or 3%. It's very small compared to, say, the general population. So that once again, like it would then get back into, that probably would not explain all of the difference between the different income groups, but might be one piece of that explanation.
Still, you had a much higher level of people without treatment plans, and you had the 10% without regular source of care, or with regular source of care. So the correlate should be that they have a doctor and they're not following the treatment plan and didn't receive one from the doctor.
Right, so with diabetes, so if I'm remembering right, almost everybody who has diabetes who's a senior has seen a doctor in the last year. Then the question would be, who are they seeing, or what kind of, are they just getting episodic care? Are they getting, chronic disease management care? The quality of what they're getting. So, right, so simply seeing a doctor is only the first step. Then you have to have a quality of care so that you're getting the appropriate treatment. Then you have to understand it so that you can you can get great quality of care, and if you don't understand what's going on, that's not as good either. Right? So there's a whole progression of steps. And I mentioned the lower incomes of these groups, so it's going to be more difficult. You have to think about things like knowledge of medical literacy types of issues in that group too, which may or may not be addressed adequately as well.
So we have to end it there, but you can see Steve's email. Feel free to follow up if you have further questions. Thank you very much, and hopefully see you again on March 10th.
Okay, thank you.